Aloha. My name is Dr. Robin Miyamoto. I'm a clinical psychologist specializing in health psychology and behavioral medicine. I'm an assistant professor and director of clinical services in the Department of Native Hawaiian Health at the John A. Burns School of Medicine at the University of Hawaii. I've been working across the state of Hawaii for the last 20 years, promoting training opportunities in primary care psychology, particularly in rural and underserved communities. I'm happy to be presenting on the determinants of health and resilience in Native Hawaiian communities. Before we get started today, I would like to offer a land acknowledgement. I offer this land acknowledgement acknowledging Hawaii as an indigenous place whose original people are today identified as Kanaka Oiwi or Native Hawaiians. The Aina of Ka'akau Kukui, which I currently reside on, is located in the Ahupua'a of Honolulu, in the Moku of Kona, on the Mokupuni of Oahu, in the Pai'aina of Hawaii. I recognize that Her Majesty Queen Liliuokalani yielded the Hawaiian Kingdom and these territories under duress and protest to the United States to avoid the bloodshed of her people. I further recognize that generations of Indigenous Hawaiians and their knowledge systems shaped Hawaii in a sustainable way that allows me to enjoy her gifts today. For this, I am grateful and recognize my kuleana, both my responsibilities as well as privileges, to care for this Aina for the many generations yet to come. Today, we're going to talk about the social determinants of health and health inequities. We're going to talk about those specifically as they pertain to the Native Hawaiian population. We're going to talk about the impacts that were felt during the COVID-19 pandemic, and then we're going to talk about some positive activities that are going on in Native Hawaiian communities. I have my own disclaimer. I may say things today that challenge beliefs and could be taken as offensive to your status quo. These are my opinions and not the opinions of the Departments of Geriatrics or Native Hawaiian Health. I raise these issues not to raise defense, but to shine a light on the inequities that prevent good health for all in an attempt to improve the systems we work and live in. I also acknowledge my marginalized status as well as my privilege when I say that I am a mixed race, Asian, Caucasian, cisgender, divorced, elderly female who went to private schools until college and is the child of healthcare professionals. I wanted to start with a quote today that means a lot to me by Austin Channing Brown. I believe firmly that to practice love is to disrupt the status quo, which is masquerading as peace. Let's start with a concept that most of you are probably very familiar with by now. Social determinants of health, or the economic, social, cultural, and environmental conditions that influence individual and group differences in health status. Our environment impacts our health either through access or lack of access to many important things, such as healthy food options, the ability to engage in physical activity in a safe way in our communities, and access to healthcare. And our environments are often influenced by our socioeconomic levels. This is a picture of our own medical school, where we have some big challenges in terms of houselessness and access to care for many of our populations. In terms of the environments that we live in, they affect all of the choices that we're able to make and not make with regard to our healthcare. We're going to be talking more about that today. So who's most affected by social and health inequities? It's the marginalized population who oftentimes don't have a voice in public policy discussions. These include Native peoples and Blacks, women, children, the elderly, the poor, and marginalized, those who are politically underrepresented, the undereducated, and those living in impoverished neighborhoods. Social policy is health policy. And as we start to change those social policies, health expectancy grows and health inequities are not natural. This is not something that should be happening. This is not something that has to do with our genetics. This is something we have caused with our environment and without policies. And we all pay the price for poor health. These ideas were pre-COVID. Then, of course, we know that 3 years ago, our world kind of exploded. It was the day that everything changed, and it really brought to light these health inequities when we think about who's most affected by COVID. It also brought the Black Lives Matter movement into focus, Asian hate. It really threw everything upside down. As a result, now we're really seeing that racism is the foundational determinant of health. So it's racism, not race, which is a social construct. That's the primary driver of those social determinants of health. It also brought the Black Lives Matter movement into focus. Asian hate, it really threw everything upside down. As a result, now we're really seeing that racism is the foundational determinant of health. So it's racism, not race, which is a social construct. That's the primary driver of those social determinants of health. This model by parodies really demonstrates that racism and racist policies are the root that we can trace all the determinants of health back to. That's where we need to start talking. This model by parodies really demonstrates that racism and racist policies are the root that we can trace all the determinants of health back to. That's where we need to start when we're talking about ways to improve this system. The social determinants of health were described as a product of circumstance, but recently they've been associated with practices and policies created by structural racism. Just so we're all on the same page, let's give a definition of structural racism. Structural racism is defined as the totality of ways in which societies foster racial discrimination through mutually reinforcing systems of housing, education, employment, earnings, benefits, credit, media, healthcare, and criminal justice. Now I want to bring it back to Hawaii and talk about racism here. We see this again with the ZICTA data that Ranjani Starr and her colleagues put together out of the Department of Health. People are always claiming that Hawaii is the healthiest state in the country with the longest life expectancy. While it's true that our entire state has a life expectancy of just over 82 years, when you look at it by ZICTAs, which are relatively equivalent to zip codes, you can see that the areas with the highest Native Hawaiian population, so out here on the Waianae Coast in yellow, as well as the area of Waimanalo, there is almost a 10-year difference in life expectancy. The distance between Aina Haina here in navy blue with a life expectancy of 87 years, that's less than 10 miles from Waimanalo, but there's a 10-year difference in life expectancy. That's because of the racist policies and where the monies are going to in terms of bringing programs that support healthy activities and health in general across our state. So racism does matter to health when its underlying resentments and anxieties shaping larger politics and policies and then affect public health. If we look at the history of Native Hawaiians before the missionaries arrived, they were a very healthy population with very low rates of obesity. There was no evidence of diabetes in the population. This was documented by the explorers before the arrival of the missionaries. So this is not a genetic predisposition that exists. The health was here. It was the changes that happened that caused the decline in health. This is too much to go over in our time together, but you will have access to this timeline that was put together by Dr. Keawe Koholokula, Chair of the Department of Native Hawaiian Health, that goes over the pre-contact and post-contact of the population with the missionaries. The most important thing to note is that the Native Hawaiian population was estimated to be between 500 and 800,000. And by 1900 was down to 30 to 50,000. And that was because of the infectious diseases that were brought by the missionaries and their crews. We can see that the arrival of the missionaries, the arrival of Christianity and colonization had a huge impact on the health of Native Hawaiians, which is not a genetic predisposition. In more recent years, as we've seen the Hawaiian Renaissance, the reemergence of the Hawaiian language, of cultural activities, we are seeing an increase in the state's population, as well as an increase in the number of Native Hawaiians across the country. It's starting to approach the pre-contact numbers. When we're talking about health inequities, it's really easy to say, oh, it's bad choices that are affecting people's health. But when we take a look at it, the factors that affect health that are related to health behaviors really only account for about 30% of health inequities. The other 70% are coming down to those social determinants of health that we were talking about, the social economic factors, the physical environment, and then access and quality of care. So when we are in the office with patients trying to get them to take their medication or eat healthier foods, we're really only impacting about 30% of their overall health. When we look at what's happened to the health of Native Hawaiians since missionary contact, unfortunately, Native Hawaiians are leading in terms of inequities with higher rates of obesity, diabetes, mental health, and substance abuse. I think the only ethnicity that has higher rates of hypertension than Hawaiians is Japanese. In all other areas, it's Native Hawaiians that are taking the brunt of those health inequities because of the racist policies and the social determinants of health. As we saw in the ZICTA slide, this means that there's a lower life expectancy by 10 years, and also that Native Hawaiians contract disease younger, 10 years younger than their white counterparts. We see this in dementia, arthritis, and cardiovascular disease. So these are the inequities that we're trying to target, but we can't do it by just targeting those health behaviors alone. Cultural determinants of health, when we're talking about Native Hawaiians, are extremely important because it's not just the environment, it's the historical and cultural trauma that Native Hawaiians were subjected to. The history of cultural marginalization, colonization, land being stolen, language banned, so that there was no way of expressing themselves in their native language and losing a lot of those native speakers. At the same time, we really want to focus on the preservation and resurgence of cultural traditions, of language, of cultural dance, of cultural practices, and also those sacred places that mean so much to Native Hawaiians and that Westerners continue to take over in the name of tourism or science. The access to lands is an important part of repairing the structural racism that exists. The importance of helping to build that strong Indigenous identity with the introduction of health-based cultural programs. These programs encourage cultural participation, but that is hard when people are working a couple of jobs and trying to make ends meet. We really need to have access to these programs, and people need to have a livable wage that allows them to participate in these programs. This is another slide that was put together by Dr. Koholokula listing out the social and cultural determinants of health. You can see the historical determinants, which goes back to those racist policies, the social, political, and social economic determinants, again, racist policies, and then the last three areas are really seeing the impact from those policies and how they affect the biological factors that we might see when a patient is in our office, as well as those mental health issues. So when we go back to this original slide from the beginning, and we're talking about the social determinants of health, we realize that similar to other Indigenous populations, and this is from First Nations in Canada, that we can't just look at the social determinants of health. There's so much more that needs to go on in terms of cultural well-being and eliminating structural racism and reconnecting people to their history and their culture as we start to look at what wellness means instead of just repairing those health disparities. When we're talking about the resilience and cultural revitalization of the Native Hawaiian population, it's so important to look at the resurgence of language. That with our Hawaiian language immersion programs, such as Punana Leo, we've seen a sharp increase in Native speakers. We've seen people returning back to traditional diets that are not simple carbohydrate based, and then also looking at different activities that get people outside and reconnected to their culture, such as voyaging, paddling, hula, and helping people to feel proud about their culture instead of focusing on so many of the disparities. This resilience and revitalization are what we can credit for the sharp increase in the population and is really going to be critical when we think about the health of the population that is increasing. So the challenge then becomes, how do we dismantle structural racism? I think we are at a pivotal point right now in terms of diversity, equity, and inclusion initiatives and what that actually means. We can have lots of trainings on it and we can make sure that everyone has checked the box and done those trainings. But unless we really start to dismantle the racist policies that underlie them, we're not going to be able to make a difference in things. This is a model that was put forth by the Aspen Institute of the 4 steps that we really need to focus on in dismantling structural racism. I'm going to take us through the steps and what is being done in the Hawaiian community to do just that. The first one is that racial equity must be a central goal of the work. When we think about what some folks have called vaccine hesitancy, that again tends to put blame on the individual, that they are hesitant in getting the vaccine, that they are not getting vaccinated, but not looking at the barriers to why that reduced vaccine uptake exists. This is a good model for racial equity, the idea of a difference in vaccine uptake. We need to be able to look at things from a more systemic approach. In terms of the barriers, a lot has been written about having trusted voices as part of the marketing campaign because there's so much mistrust of medicine and science. This mistrust is coming from a reasonable place. There's a long history of unethical practices and research on minority populations. There's a long history of racism in their individual healthcare. And so they don't always have the relationship with healthcare providers that someone else may, that has always had very positive experiences. Overcoming those barriers meant getting people out in front. We needed to get recognizable, trusted voices to talk about the importance of vaccination. And this was really a useful practice, but it fell short of true partnership. True partnership really requires partnering with those trusted organizations that already have ties to the historically marginalized communities. Native Hawaiian and Pacific Islander organizations who've been there before COVID, who've developed these relationships and can have a very hands-on approach and roll up their sleeves and get into the work, because those are the folks that people are going to trust when it comes to, should I or shouldn't I get a vaccine? This brings us to the role of community health workers. They have become so important in terms of the high touch versus high tech. They really demonstrated the importance of person-to-person communication. In communities with the highest risk of infection, which was early on the Pacific Islander community, the local community health workers were really the ones that were able to get more people tested, connecting them with the care that they needed, and eventually they were the folks that were able to increase vaccination rates, to get into the communities. They understand that they don't have all the knowledge and that they're paraprofessionals, but they do know that they have ties to the community that physician providers don't, and that the relationship was really key to increasing vaccination rates. They were also crucial in terms of language and translation skills and going into these communities. In this high-touch, high-tech situation, again, we need structures, policies, and practices that are focused on ensuring Black and Brown communities in clinical settings receive doses of vaccines in a timely manner. To get back to equity and vaccine distribution, we really need to look at mobile units and pop-up clinics. We need to look at partnering with local community organizations or individuals in order to advance health equity. When we're talking about equity and distribution when it comes to vaccines, Dr. Giselle Corby, who is a Black cardiologist from North Carolina, really felt that vaccine hesitancy, that term, and the concept were really a scapegoat for structural racism. And so when we are looking at equality, which is the top line of the slide, where everyone gets the same bike regardless of their size or need, we don't hit the population that we need to in order to fix those health disparities. It is only when we look at equity, which is that everyone gets the bike they need for their size or situation, that we're able to get vaccine rates up. So when you give everyone equal access, as we did with online scheduling of vaccines early on, it exacerbated inequities in vaccine uptake. The disparities got wider and wider. We saw unequal access to internet and computers, which made it difficult for people to be able to schedule their vaccines. We saw huge lines, and people weren't able to get their vaccines in a timely manner. If any of you tried to get the free COVID tests from the federal government, you weren't able to get them if you lived in an apartment. The first time the system rolled out, it wasn't built for anyone in an apartment to get a test. You could only order a test if you lived in a single family home. This brings us back to that equity versus equality conversation. Because minorities are so disproportionately disadvantaged in the institutions in our society, attending to their needs in these action items with lower priority or as an afterthought is not enough to develop long-lasting solutions. We really need to look to the core, informing mission statements and programmatic goals around these populations if we're going to see improvement in any of these areas. We saw with COVID, obviously, that there were extreme disparities in terms of how it was hitting different ethnic groups. And this is the number 2 piece of things. This is where we need to counter popular assumptions that work to reproduce the status quo. When we're thinking about how it was affecting minority groups, we really started to think it was because of the bad choices that Brown and Black people were making when it came to COVID. This is the COVID Racial Data Tracker, which is a national tool that was started at the beginning of COVID. They have stopped collecting data at this point, but you can see here that Pacific Islanders were particularly hard hit, with 41% of the cases in Hawaii and 32% of the deaths, despite only being 10% of the population. It's very easy to make the assumption that Black and Brown people were not taking the virus seriously. They weren't social distancing. But when we got a lot of the survey data back, they were actually taking it more seriously than their white counterparts. Then at that point, people started to say, oh, it's their pre-existing health conditions. They're obese, they have diabetes, they have lung conditions. But no, it all came down to racist policies. We need to be able to change those policies if we're going to be able to address these health disparities. This is Hawaii-specific data here. This is the pre-vaccination period, and for Pacific Islanders, they were accounting for 25% of the cases with a much lower representation in the population. This is because they were our frontline workers. They were at the grocery store, they were at the fast food places that were still open, and they were living in multi-generational households where you couldn't isolate if somebody in the house got COVID. So this is where we're seeing those racist policies play out. Only once we had the vaccines available, you can see the difference here. The rates are more on par with their representation in the population. But when we switch over to Native Hawaiians for the post-vaccine status, that's where we see the vaccine uptake is not as high. Not because of them being more at risk for contracting COVID, but because of the exposure to racist policies, they've developed a mistrust of the healthcare system. We didn't see the vaccine uptake we were hoping for. During COVID, there were a lot of these health disparities that we've talked about today, but also a lot of solutions that came out of those. COVID created a state of emergency that allowed communities to do what they do best, think outside the box without having to worry about the typical red tape imposed by state and federal agencies. Among other lessons, the COVID-19 pandemic taught us that communities have the power and agency to quickly create necessary change that is responsive to their residents' needs. Thank you so much for your attention today. I hope this information is helpful.